To our researchers, thank you for joining this forum and congratulations for reaching this stage. And we now begin the presentation proper. So let me call on our first presenter, Dr. Faranas Inawat Abdul Mahid from the Philippine Heart Center. Everyone, let's give her a big welcome. Dr. Faranas.
The increase in mortality of population over time in certain locality reflects its urbanization. Thus, discoveries are entrenched to come up with easy yet advanced way to recognize the cause of death to uplift the integrity. Hi, I'm Dr. Faranas Inawat Abdul Majid, cardiovascular surgery from Philippine Heart Center with co-author Aisel Catalan. Rheumatic heart disease, RHD, is a condition in which the heart valves have been permanently damaged by rheumatic fever. The heart valves can be inflamed and become scarred over time. This results in narrowing or leaking of the heart valve, making it harder for the heart to function normally. This may take years to develop and can result in heart failure. According to WHO data published in 2018, RHD in the Philippines reached 2,781 or 0.46 of total deaths. A significant number of people who do not receive any adequate nutrition, sanitation, and medical care living in congested colonies consequently will suffer from recurrent attacks of rheumatic fever, and severe valvular disease develops within 5 years from the initial episode. Valvular heart disease is one among several possible causes of severity of pulmonary arterial hypertension. Pulmonary arterial hypertension is common among patients referred for mitral valve surgery. Although it is generally acknowledged that the presence of pulmonary arterial hypertension has a negative impact on operative outcomes, available data are remarkably scant and generally from small series. Current American College of Cardiology, American Heart Association, and European Society of Cardiology's guidelines recommend surgery for asymptomatic with mitral regurgitation with resting systolic pulmonary artery pressure greater than 50 mm mercury as a Class 2A indication. Late onset of the disease will present with pulmonary arterial hypertension, which is proven to provide poor outcome. Thus, this study was conducted to determine the outcomes of RHD patient who underwent mitral valve surgery with severe pulmonary hypertension, specifically to determine the demographic and clinical functions, the surgical factors, and to determine the frequency of prolonged ICU stay, frequency of prolonged intubation, frequency of pulmonary hypertensive crisis post-operatively, and deaths affecting outcome. This study just conducted through chart review from a single institution as a tertiary care referral center for cardiac diseases. The records obtained from January 2013 to December 2019 included in the study are adults 19 years of age and older with rheumatic heart disease, mitral valve disease with concomitant severe pulmonary arterial hypertension who underwent mitral valve surgery with or without tricuspid valve repair. This list of patients was collected from the Census of Operation from 2013 to 2019. Data was obtained from the medical records of patients who have fulfilled the inclusion criteria. Demographic data, comorbid illnesses, echocardiographic findings, and operative techniques were obtained. Patients' outcome, including the morbidities and mortalities, were recorded, and the data collected was then analyzed. Descriptive statistic was used to summarize the demographic and clinical characteristics of the patients. Frequency and proportion were used for categorical variables, median and interquartile range for non-normally distributed continuous variables, and mean and SD for normally distributed continuous variables, independent sample t-test, Mann-Whitney U-test, and Fisher-Exact or chi test were used to determine the difference of mean, rank, and frequency, respectively, between patients with and without outcome. Odds ratio and corresponding 95% in confidence interval from binary logistic regression was computed to determine the significant factors associated to outcomes after valve surgery. All statistical tests were two-tailed tests. Shapiro-Wilk was used to test the normality of continuous variables. Missing variables was neither be replaced nor estimated. Null hypotheses were rejected at 0.05 alpha level of significance, and STATA 13.1 was used for data analysis. There were 103 participants enrolled for this study, diagnosed with rheumatic mitral valvular heart disease, and on preoperative echocardiography showed severe pulmonary arterial hypertension. Those patients underwent mitral valve surgery with or without tricuspid intervention, with the mean age was 49.26 plus minus 1.23, and majority were female and 41 were male. The demographic profile of the patient shown in Table 1 states that the NIHA classification was significant with p-value of 0.011, and distribution showed class 1 and 2 were higher among those patients with no outcome, while class 3 and 4 were higher among patients with outcome. Arrhythmia is correlated with positive outcome with p-value of 0.020. There were 23.40% of patients with outcome who have arrhythmia, while patients with no outcome have arrhythmia were 7.14%. Renal disease is correlated with positive outcome with p-value of 0.026. There were 8.51% of patients with outcome who have renal disease, while patients with no outcome have no renal disease were 0%. Who have renal disease were 0%. The rest of the demographic profile were not significant to the outcome with p-values above 0.005. The preoperative 2D echo findings and the surgical technique showed no significant variables affecting the outcomes. Outcomes noted with ICU stay, duration of intubation, duration of chest tube drainage, respiratory and renal events, arrhythmia, reoperations, and patients who died, noted that a third of patients had prolonged ICU stay. 14 patients with respiratory failure and 18 out of 103 developed arrhythmia persistently post-operatively, and 8 patients were noted mortality. For the binary logistic, the New York Heart Classification noted to be significant risk factor for unfavorable outcome. Patients with NIHA class 1 were 4.1 times least likely to have an outcome as compared to the NIHA class 2. However, the p-value was above 0.05, which means that the category was not significant. But the patient with NIHA class 4 were 6.5 times more likely to have an outcome as compared to patient with NIHA class 2. And arrhythmia noted preoperatively was correlated with negative outcome with a p-value of 0.020, where there were 23.4% of patient arrhythmia had unfavorable outcome versus 7.1% without arrhythmia. Thus, this result indicated that preoperative evaluation of patient was valuable for good prognosis. Rheumatic patients with mitral valve pathology and severe pulmonary hypertension with NIHA classification and comorbids of renal disease and arrhythmia preoperatively have an incremental risk of poor outcome after corrective surgery. Therefore, the NIHA classification we therefore conclude that the NIHA classification and arrhythmia preoperatively is statistically significant in affecting the outcome of patients with rheumatic valvular heart disease and consequent pulmonary hypertension undergoing corrective surgery. This study recommends to have registry for cardiovascular surgery to increase the number of participants and to utilize online registry, and also to justify the mandate of RDOH to come up with a regional heart center and to appropriately tag patients preoperatively in severity of the patients to have an adequate management. So will you be part of these changes, rethink, and how to contribute to health? Thank you.
Thank you very much, Dr. Paranas from the Philippine Heart Center. Now we move on to our second presenter. May I call on Dr. Elisa Dayan Soriano from the Philippine Heart Center to discuss her research outcome of percutaneous transcatheter device closure of ventricular septal defect in children weighing less than 10 kilograms. Dr. Elisa?
Good afternoon. I am here to present my paper on the outcome of percutaneous transcatheter device closure of ventricular septal defect in children weighing less than 10 kilograms. I am Dr. Elisa Dayan Soriano from the Philippine Heart Center. Ventricular septal defect, or VSD, is the most common congenital heart disease in children. The shunting of blood across the VSD causes increased pulmonary blood flow, which may eventually lead to pulmonary congestion and heart failure, and the only definitive treatment for this lesion is closure of the defect. VSD closure can be done surgically, wherein a patch is sutured in place while the heart is on bypass, or it can also be done percutaneously via transcatheter device closure. This approach is preferred by most cardiologists because it is a lesser invasive procedure compared to open heart surgery with a relatively faster recovery period. However, this procedure is not commonly done in smaller infants because of the relatively smaller vessels, which can be damaged when large caliber catheters and delivery sheets are used. The availability of newer devices such as the multifunctional occluder, or MFO, which is a soft, low-profile device and uses smaller caliber delivery sheets and catheters, now allows percutaneous transcatheter VSD closure in infants. The objective of this study is to describe the outcomes of transcatheter device closure of VSD in children less than 10 kilograms. This is a cross-sectional study, and our population includes all patients ages 0 to 5 years old and weighing less than 10 kilograms who underwent VSD device closure from December 1, 2019 to April 30, 2020. Those patients with complex heart disease and those with other interventional procedures done other than a simple hemodynamic studies and transcatheter device closure are excluded in this population. The patient's demographic data, baseline and follow-up echocardiographic parameters, as well as intraprocedural details and outcomes are recorded and analyzed. Majority of the subjects were 13 to 23 months old with a mean age of 16.7 plus or minus 8.56 months. 70% weigh more than 6 kilograms, and about half or 50% of the subjects were classified as severely underweight based on the Z-score for age. Pre-procedural echocardiographic parameters of the study group are presented in this table. All subjects had a hemodynamically significant shunt with a mean QPQS of 2.33. The left ventricular end diastolic dimension of the subjects are also above normal with a mean Z value of 2.1 plus or minus 1.91. And 70% of the subjects had elevated pulmonary artery pressure based on echocardiogram. Intraprocedural details are shown in this table, and you can see that 90% had a perimembranous type of VSD, while one subject had a subpulmonic type of VSD on angiogram. For all the subjects in this study group, a multifunctional occluder, or an MFO, was used, and the delivery sheets used ranges from sizes 4 French to 7 French. This study reported 100% procedural success with no cases of device embolization or aborted procedure. 60% of the total population reported intraprocedural blood loss requiring transfusion, of packed red blood cells, and the patients had a mean hospital stay of about 3.6 days. 1 month post-procedure, 90% of the subjects had no residual shunts. On the other hand, one of the patients with a large VSD had residual shunt measuring about 0.3 centimeters. New onset tricuspid regurgitation was also noted in one subject. Furthermore, the left ventricular end diastolic dimension showed improvement based on the Z value, and the pulmonary artery pressure also improved, wherein 70% now have normal pulmonary artery pressure post-device closure. Comparing the baseline with the follow-up parameters, there was a noted 16.53% increase in the weight of the subjects, a 33.16% decrease in the pulmonary artery pressure, and a 7.37% decrease in the left ventricular end diastolic dimension. The difference of the left ventricular dimension based on Z value is significant and comparable to the report of Yang et al. In 2014, wherein they reported improvement in the left ventricular end diastolic dimension Z value after 2 years of transcatheter device closure of the VSD. Similar to the study of Yang et al., the complications are categorized as minor or major adverse events. No major adverse events were noted in all the subjects, and minor adverse events recorded were only blood loss requiring transfusion, the presence of a residual shunt on follow-up echocardiogram, and new onset regurgitation. In conclusion, this study reports 100% procedural success with only minor complications noted. Armed with newer devices like the multifunctional occluder and smaller caliber catheters, percutaneous device closure of VSD in small infants can be done successfully. We recommend doing a larger multi-center and prospective study with longer follow-up to further evaluate the feasibility and long-term results of percutaneous transcatheter closure of ventricular septal defects in children. Thank you.
Thank you very much, Dr. Elisa. Now we move on to our third presenter. May I call on Dr. Hanilet San Reyes from the Lung Center of the Philippines to present her research, the outcomes of evolving treatment regimens among COVID-19 confirmed severe and critical cases admitted at the Lung Center of the Philippines. Dr. Hanilet.
Good afternoon, ma'am. Do you wish to present my paper?
Go ahead.
Okay, good afternoon. It is my honor to present to you our paper, The Outcomes of Evolving Treatment Regimens among COVID-19 Confirmed Severe and Critical Cases Admitted at the Lung Center of the Philippines. I am Dr. Hanilet San Reyes with my co-authors, Dr. Ricardo Pangan III and Dr. Maria Charisma Laborte. In December 2019, the novel coronavirus SARS-CoV-2 and its disease COVID-19 was diagnosed in a series of patients in Wuhan, China, and has marked the start of a global pandemic. SARS-CoV-2 pneumonia may present as a mild case to critically ill. The Lung Center of the Philippines is one of the designated COVID-19 referral hospitals in the country. As of August 2020, it has recorded a total of 1,344 COVID-19 confirmed cases, with 256 COVID-19 confirmed deaths. Currently, there are limited studies available on the management strategies and outcomes of COVID-19 confirmed severe and critical cases admitted at the ICU. This study aims to describe the outcomes of evolving treatment regimens among COVID-19 confirmed severe and critical cases admitted at the Lung Center of the Philippines. For a general objective to describe the treatment outcomes of COVID-19 confirmed severe and critical cases admitted at the Lung Center of the Philippines. This is a retrospective cohort study conducted at the Lung Center of the Philippines from March 2020 to August 2020. There are 219 COVID-19 confirmed severe and critical patients included in the study out of the 526 COVID-19 confirmed cases that were screened. 15 patients were excluded because of lost medical records. In this study, LCP standard of care 1 consists of antibiotic therapy, multivitamins, zinc, oxygen therapy, IV fluid, and management of comorbidities. LCP standard of care 2 consists of standard of care 1 plus anticoagulant plus dexamethasone. Majority of the patients belong to age group 60 to 69. The mean age of survivors was 59.05 and mean age of non-survivors was 62.78. Majority of the patients and non-survivors were male. CKD was associated with severe COVID-19. Patients with CKD were more likely to die. This is the table of the proportion test on treatment regimens in severe and critical COVID-19. Of the regimens, treatment regimen 19, which is standard of care 1 invasive ventilation, and treatment regimen 38, which is standard of care 2 with mechanical ventilation, appears to be significant and increases the likelihood of death. A Cox regression analysis showed that Apache 2 score were associated with increased probability in death. The higher the Apache 2 score, the greater the probability of death. Regression Cox analysis on PF ratio, survivors versus non-survivors, showed that PF ratio is associated with an increase in the probability of death. The higher the PF ratio, the higher the probability of death. For our conclusion, patients in combinations that included invasive ventilation have higher Apache 2 score, lower PF ratio score, shorter hospital stay, and were more likely to die. The use of high-flow nasal cannula in standard of care with anticoagulant and dexamethasone decreased the likelihood of death. This is a retrospective study that relied on data that were recorded in medical charts by the attending physicians. The population is small for the number of treatment combinations obtained from this study. For our recommendations, a future study be undertaken focusing on the 11 combinations of treatment regimens that were found to have significant difference in the proportion of survivors and non-survivors for supportive evidence for potential treatments in COVID-19. A continuation of the study is also recommended to further describe the continuously evolving treatment regimens and its outcomes in severe and critical COVID-19 patients. Thank you.
Thank you very much, Ma'am Hanilet. Apologies for the technical difficulty. Now, we move on to our questions and answer portion. Again, thank you to all our presenters for their papers. Let us now hear some questions from the audience. Ma'am Joy, can you start with our first question, please?
Thank you, Dr. Gian. First question comes from Ma'am Phoebe Kabab. Her question for the first presenter: how will this study provide faster or timely access and treatment of the heart patients? So, I repeat the question. Yes, Doc.
Yes, thank you for that question. Well, at the background of heart diseases, we can address it faster and timely. First, by recognition of the disease, with our knowledge of the heart disease by our internal medicine or our counterpart cardiologists, from the start of the onset of rheumatic fever pa lang, if adequately recognized, and it will not take time to 5 years, it will not ensue unto rheumatic valvular disease that warranted surgery. From there, we can access sana adequate also or appropriate cardiologists na around if not recognized by the internal medicine. At the same time, since actually the DOH had mandate on coming up with the regional heart center, so hopefully if it is feasible, then it is accessible institution, not just Philippine Heart Center, to address timely the problem of the heart patients.
Thank you very much, ma'am. So we are glad that your study can actually contribute to these patients very significantly. And we're also happy that you've mentioned an initiative of the DOH, and we're very glad that you are validating the need for that intervention, which is regional heart center. So thank you, ma'am. And thank you, Ma'am Phoebe, for that question. Ma'am Joy, do you have other questions in the chat box?
So far, Doc, we don't have any more questions in that chat box, Doc.
Okay. Siguro, do we have more time pa ba, ma'am? So we are encouraging all participants to type in your questions. I think we have ample time to discuss some of your questions po. Sige. So siguro while our participants are thinking about their questions, I'd like to ask the same question siguro to our second presenter. So, Doc, how about your paper po? How can it positively contribute to our patients in their care, and what do you think, Doc Elisa? How can your paper po contribute?
Hello, good afternoon, everyone. So my paper on the percutaneous transcatheter closure of VSD in small infants, although this procedure is not that common in pediatric cardiology, knowing that this procedure is effective and safe, eventually we can recommend this procedure routinely in patients with significantly hemodynamically significant shunt. So even if we are not yet doing this, because this is the pilot study in the Philippines, at least now we have an idea that this procedure is feasible, this procedure is safe, and this procedure is doable. So if we have smaller patients who are not yet that stable or not amenable for surgery, then we know that we have another option. So I guess that is the significance of my paper. We now have a baseline data on the effectiveness of percutaneous transcatheter device closure in small children. Thank you.
That's nice. Thank you, Dr. Elisa. That's nice. So we have alternatives pala. Although it's still under pilot, no? But we're very glad with this findings po and papers. Ma'am Joy, do you have other questions?
Another question from Adrian Doctolero. To the third presenter, how will this affect our current interventions or practices managing COVID-19?
Thank you for that question. Thank you for that question, doctors. Actually, we still don't have a gold standard for the management of COVID-19. So everything else is based on very evolved. That we know from this study is that a patient, when mechanically ventilated, has lesser chance of survival compared to the others, let's say, who are on high flow nasal cannula. So if we can reach patients with high-flow nasal cannula to avoid intubating them unless it is really necessary, I think high-flow nasal cannula would give them a better chance of surviving. In these studies, we did a combination, so it is really difficult to say which one or individual regimen works best or would benefit COVID patients because they were all given simultaneously, just like what we are doing now. What we could do is from this study is that the combinations or the regimens, the top 11 out of 68 that showed significant proportions, we could focus on them. The problem with the study is that the population is too small for the number of combinations that we've had. So we can extend the study, include more subjects, and focus on the regimens that showed promises or benefits for the patients.
That's nice. Thank you, Dr. Hanilet. Thank you for that question, Sir Adrian. So we're also glad that some papers are very relevant to today's pandemic. Ma'am Joy, do we still have time to answer more questions?
Doc, we have until 2 p.m. to for the question and answer.
So
However, as of this moment, there are no additional questions in the chat box.
sige po. So sige. So if we have more time, I can ask questions since I'm very interested with the paper. So just to follow up yung sinabi ni Dr. Hanilet. Doc, what about what is the process po ba now that you have local papers like this for treatment regimens for COVID? What is the process for that to be yung sinasabi nyong standard or yung maging national treatment guidelines, at least kung hindi man siya standard internationally?
There have been several studies already, like the solidarity trial, the recovery trial, and it does give us an idea of which medications or interventions to give. But up until to this time, especially with the appearance of new variants, we still don't have the gold standard for it. So it would need intensive studies and further investigations which drug really works. And madami po tayo. We have a lot of ongoing trial now, like the molnupiravir studies for moderate COVID patients. It doesn't stop. So what's very good with our science now is that it continuously studies and discovers treatments that would benefit our COVID patients. Since we still don't have the gold standard for it, then why not? We can do all the combinations of regimens that we think would benefit the patient, since every medication or intervention addresses different kinds of issues and problems in a COVID patients. Like you have your anticoagulants, which addresses the microthrombosis. We have the steroids, the dexamethasone, which addresses the inflammation in COVID patients, or say the remdesivir or the other antivirals, which lessens the viral loads of COVID. But we still have not discovered this drug or intervention that would really eliminate or kill the virus. So I do encourage everyone to continuously study and investigate on these drugs.
I see, Doc. So how about how does this relate to our vaccination program? Does this complement, Doc, or what have you learned so far?
they go hand in hand. Now we know that vaccination would protect us from developing severe to critical cases. So it does not give 100% proof that we will not be affected with COVID or infected with COVID. But with vaccination, it lessens the transmissibility of COVID and the severity of the disease, which would really lessen the burden in our economy, healthcare-wise, because of, when you're severe and you're critical, it's really costly for our government and the hospitals. So I think that everyone should be vaccinated. Yes, I believe in that. And follow the protocols. It always begins with ourselves. So even if we are vaccinated, we still have to follow the protocols. Wash, cover, protect, wear your mask or face shield, and do not go out if it's not necessary.
Okay, thank you. Thank you so much, Dr. Hanilet, for providing answers to our question. Ma'am Joy, um, what is our time left po ba for this session?
Doc, we have still 8 minutes for the Q&A, and from 2 p.m. to 10 p.m. At 2 p.m. to 2:10 p.m. is our synthesis and wrap up.
All right. So for the
For-
remaining 8, yes, Ma'am Joy,
So far, right now, Doc, no more questions in the chat box.
the chat box. All right. For the remaining 8 minutes, I'm encouraging everyone to type in your questions still. We have ample time pa. Siguro I'll go back to our first presenter. So kung walang magtatanong, I'll I'll ask questions po. So to our first presenter, ma'am, so you shared kanina how this can provide help provide access in the future for our patients with rheumatic disease. Ma'am, how about the cost? Are your recommendations um, um, help access their access financially po?
For the cost effectiveness of treatment, it is really cost effective if it will not ensure to valvular heart disease that warranted surgery. So it's just a medication that part of the, I think the ZBEN, the benefit patient will can use the benefit by with the PNG free, I think, for the antibiotics. And for the valvular, if the patient needs surgery, well, for the cost, I think it's really costly to undergo heart surgery in any ways. So the only thing is that, well, prevention is really wisely must be is the appropriately needed for the valvular diseases, but not all with the valvular heart disease warranted surgery. So there are medications that is lifelong to continue. So, but these medications are available in low cost, and our government agencies also can give support for the patients who will undergo heart surgery, especially for the replacement, because the valve replacement would cost from 250,000, just the valve, from 80,000 to 250,000. So it's really costly. So the target of our of the DOH, I think, is that the health promotion. So the recognition of the disease and the prevention of the disease.
Thank you, Doc. Thank you. So admittedly, surgeries are really costly, so we have to focus really on health promotion, and then so konti na lang po yung kailangan mag-undergo ng heart surgery. So thank you very much for that. Um, so, Ma'am Joy, wala na tayong question?
Doc, so far wala naman na pong nag-post ng questions nila.
All right. Sige po. So, I think we can now begin our synthesis, if that's okay, Ma'am Joy.
Yes, Doc.
Okay. Thank you to all of our participants who given their time to present their researches. Thank you also to our guests here in our session who asked questions then. Thank you po, and those who participated and listened. So these questions po will be part of our documentation of the activity. So again, congratulations to our dear colleagues for their well-made research papers in the different clinical fields. So we have from heart surgeries, and we have for COVID infection. So I hope that we can continue to encourage other clinicians po to endeavor to make these local researches that would positively influence our clinical practice guidelines and eventually improve the health outcomes of our Filipino people. So before I give the final reminders, allow me to provide a quick synthesis of our session. So very briefly lang po, no? We listen to researches about factors affecting outcomes of heart surgeries for our rheumatic patients, as well as children with ventricular septal defect weighing less than 10 kilograms. So, and we've also learned about the outcomes of evolving treatment regimens among COVID-19 confirmed severe and critical cases. We've heard their recommendations about improving registries for this, so we can study their our population better, and recommendations on how we can better manage our patients today. So let me share a few of my learnings in this session. So for me, it is important to encourage three things. First, evidence generation that is tailored fit for our population. So majority po kasi of our practice guidelines currently are based on literature which studied Western people or other people, not the Filipino people. So our population may have these unique characteristics. Not to mention, we have a unique health system. So that's why it's very important to improve our registries and even our facilities, no? So evidence generation can help trigger changes that we need. So second, this is related to my second point, that are to design researches that improve patient outcomes and access. And these researches hopefully can recommend changes to our current clinical practice guidelines. So like our COVID treatment, standard treatment, hospital operations, so how we manage our heart patients, public health programs, how we tailor fit our policies as well. And third, it is important to encourage the dissemination of these findings, ito pong findings of the research, to spark interest and discussion, as well as to improve our overall health system. So it is important that others are made aware of these researches and that these findings do not just remain within our institution. So those po are the three of my highlights for this discussion. So again, thank you and congratulations to our presenters. Just a few reminders before we end. Make sure you are able to log in to the next parallel session on time. As some of you are aware, there are 30 papers out of 60 presented in this forum that are running for best research paper. The winners will be announced and awarded at the closing plenary session of this forum. We hope you can join us during the closing ceremonies. Before the first National Hospital Week Research Forum formally closes, the link to the post-activity evaluation form will be announced and posted. Only those who will be able to accomplish this online post-activity evaluation form will receive a certificate of attendance in return. So again, kindly fill out the post-activity evaluation forms to receive your certificate. And I think that ends our parallel session on treatment and management, clinical and public health track of the first National Hospital Week Research Forum. Thank you everyone for your participation.